A warm good afternoon after the post-lunch session. I don't know, I think all of them are, all the delegates are in the lunch room. So this session is about challenges in congenital cataract and some reflective insights into the management of congenital cataract. We have with us Dr. Elizabeth Joseph from HOD, pediatric HOD of ophthalmology, Little Flower Hospital, Angamali. Dr. Saumya, senior consultant in pediatric ophthalmology, Comtrust Eye Hospital. Dr. Meena, senior consultant in pediatric ophthalmology, Little Flower Hospital. Dr. Satish Thomas, Chief of Pediatric Ophthalmology in Believers Church Hospital. So let us start with Dr. Saumya Nambiar, who will talk on systemic and ocular associations in congenital cataract. Over to Dr. Saumya.
Good afternoon, everybody. So I do not know, most of them here are pediatric ophthalmologists or we have come here for relaxing after lunch. So anyways, I think pediatric cataract is all the more important because of the visual impairment that it causes and which is a lifelong visual impairment for the child. I think that is the most important aspect of detecting congenital cataracts earlier on. So cataracts which are found within first 12 months of birth is the way we describe a congenital cataract. And a meta-analysis showed that the prevalence of cataract was between 2.2 per 10,000 to 13.6 per 10,000 of cases worldwide. Now, why is early detection important? One, because it is one of the most treatable cause of lifelong visual impairment. And secondly, it's most amblyogenic when compared to other forms of amblyopia. Before knowing the cause of congenital cataract, we should have a little bit, I have just shown the slide to emphasize the importance of embryology in this aspect. So we know that the lens starts developing by 27 days after there is a multiplication of the surface ectoderm and then forms the lens vesicle, which then detaches itself to form the lens vesicle. And in the lens vesicle, as you can see onto your left-hand side, in the posterior aspect, there are cuboidal cells which slowly starts becoming columnar and gives rise to the first or the primary lens fibers initially by 50 days of gestation. And after that, the equatorial cells will form the secondary lens fibers. So importance of this is that injury anywhere between this, that is the first 3 months of gestation, causes the embryonic type of cataract. Unilateral congenital cataracts are usually sporadic. It's the bilateral pediatric cataracts which are frequently inherited or it represents a manifestation of underlying systemic disease. So what is the need to know about these associations? Only a knowledge of these ocular associations will help us to plan the management, help us in looking out for complications and plan an early reference to other subspecialties like glaucoma, retina, or cornea. And a knowledge of systemic associations helps us to guide the systemic workup, appropriate referral to broader specialties like a pediatrician or a neurologist or an orthopedician. Where do you have to send the child? You should know beforehand when you see the type of cataracts. So what is this type of cataract, which is most commonly seen? I'm just going to deal the commonest type. So what is this, if you can, anybody in the audience? It's a blue dot cataract, which is commonly seen with Down syndrome. It's a trisomy 21 associated case. So here, what are the most common ocular features that you see in Down syndrome? So as you can see, the refractive errors, which are most commonly associated with Downs, includes hyperopia, astigmatism, esotropia, and accommodative lag. And because of that, there may be amblyopia. There may be nystagmus also associated when it is detected later on. And anterior segment abnormalities like slanting palpebral aperture, blepharitis, and NLD obstruction can be associated, and don't miss out keratoconus in these cases. A posterior segment examination may show a small optic nerve head, an anomalous optic nerve head insertion, and small cup to disc ratio. Remember to look out for these systemic associations in a child with a Down syndrome. Look out for the congenital heart disease. Look out for death from infection, particularly respiratory related could occur. Hearing impairment could be associated. Sleep disorders, hypothyroidism, dysphagia, and dementia could occur along with Down syndrome. Now this is the second case. So what is this? This is the most commonly seen in Indian scenario is the rubella cataract. So congenital rubella syndrome, it's an important public health problem worldwide with an estimated 100,000 infants born with the disease annually. And in India itself, just look at the incidence, it is around 65.5 to 225.6 per 100,000 live births. And mothers infected with rubella virus during the first trimester of gestation have reported to have 80 to 90% chance of fetal transmission to the child. Rubella infection is thus a leading vaccine-preventable cause of birth defect and fetal death in developing nations. And the most common ocular associations that you have to look for when you see a child like this is microphthalmia, microcornea, and iris hypoplasia. You will see that the pupil it's not dilating much, and glaucoma can occur in 6 to 10% of congenital rubella syndrome. And in the fundus, look out for salt and pepper fundus appearance. Systemically, always look for a deafness that is present, a heart anomaly which is most commonly a patent ductus arteriosus, peripheral pulmonary artery stenosis. You can have encephalitis, microcephaly, and autism. So this was a paper by Vijayalakshmi et al. Wherein they showed that most commonly in these kids with rubella cataract, a microphthalmia, cataract, and iris hypoplasia occurs. And systemically, most oftenly you see the patent ductus arteriosus. So the classical triad of congenital cataract, hearing impairment, and congenital heart disease is seen in 10 to 50% of laboratory confirmed cases of congenital rubella syndrome. And how do you detect it? It is usually to get a diagnostic evidence of rubella virus is a nested reverse transcriptase PCR of lens aspirate. It is the most sensitive and rapid technique for detecting rubella virus. Genetic testing should be always contemplated in all these cases whenever you find a bilateral pediatric cataract, because you may not get a cause for all of these cases. So sometimes a genetic testing have to be done, and do not forget to do a metabolic and infectious testing as well. Next common is the persistent fetal vasculature, which we see. The infant aphakia treatment study, wherein they also looked out for the unilateral cataracts, they found that the persistent fetal vasculature was most common cause associated with unilateral cataracts, and most of them had ocular associations, and most of them had this unilateral congenital cataract. And this PFV can have varied kind of presentation. So you can see how it can be from a small Mittendorf's dot. It could go on to a vascularized posterior capsular plaque or remnant of fetal vasculature in the posterior lens capsule and the optic disc. So it depends upon what type of PFV are we dealing with, whether it is an anterior PFV, a posterior PFV, or a mixed one. So in an anterior PFV, look out for shallow AC, look out for engorged iris vessels, look out for the retrolental membrane and elongated ciliary process. In posterior PFV, always look out for the vitreous traction, optic nerve hypoplasia, a retinal detachment, and microphthalmia. Systemic associations can be seen usually with bilateral cases. Now suspect PFV in any child with unilateral cataract with microphthalmus, and always remember to look out for other causes of leukocoria as well, like that of the retinoblastoma, wherein a B scan and UPM may be useful to look at to detect the calcification. Now this is a case of anterior lenticonus, and you have to look out for the presence of Alport syndrome, which is a basement membrane disease. Systemically, look out for acute hemorrhagic nephropathy and deafness. In fundus, you look for the albipunctatus spots. This is a case of posterior lenticonus with a posterior polar cataract, and look out for the condition of Loeys oculocerebrorenal syndrome. So you have these three associations. Posterior polar cataract management is complicated, so you have to be good enough to detect it. Now this is a case of oil droplet cataract. It is one of the reversible causes of congenital cataract, which if it is detected earlier on. This is a case of aniridia with cataract. And cataract develops in 50 to 80% of patients with the familial aniridia. And what do you have to look for in addition is look for glaucoma, look for corneal vascularization and pannus, look for optic nerve hyperplasia, nystagmus, and strabismus. And genetic testing, which will be dealt with in the next session. I just put this slide to show you that these are the associations that can occur with the genetic evaluation. And these are the other systemic conditions which can be associated with cataract. So thank you one and all.
Thank you, Dr. Saumya, for that very nice presentation, nice slides and nice talk. Now I'll request Dr. Laila Mohan to present her talk on genetics in congenital cataract. Now, genetic study is becoming more and more important, and we are doing it more and more frequently. Dr. Laila, please give your talk.
Thank you. Thank you, Dr. Elizabeth. So, genetics, which we don't regularly do in every congenital cataract. So, as already pointed out, congenital cataract is the main cause of treatable blindness in children. And intrauterine infections account for about 20%, which is more common in developing countries like in India. And about 50% of bilateral congenital cataracts are inherited. And inherited cataracts may present at birth, may be congenital, or during infancy or later, much later during the first or second decade also. And most of the non-syndromic inherited cataracts are autosomal dominant, but recessive or X-linked can also occur. And syndromic associations with metabolic disorders like galactosemia, chromosomal abnormalities like the most common being Downs, or multi-system disorders like Lowy syndrome are not uncommon. And gene mapping in congenital cataract can throw light into the molecular pathology in development of cataract, both in congenital as well as in age-related cataracts. So, some of the genes causing cataract. The lens transparency is maintained by lens crystallins, membrane proteins, and filament proteins. Recently, the role of chaperones, growth factors, collagen, and extracellular matrix components have been shown. And in congenital cataract, severe gene mutations lead to damage to lens proteins. In adult cataract also, a destabilization of proteins make it more susceptible to environmental insults like UV light, hyperglycemia, and oxidative stress, making some patients more prone to develop cataract earlier than others. So there are about more than 100 loci and 56 causative genes identified in causing cataract. So genes for the eye and lens have been identified. PAC6 was identified as a master control gene. Dr. Saumya has pointed out the developmental sequences from 22 days onwards to 23 days from lens placode to pit vesicle and separation. It has been shown that PAC6 is the control gene for eye development by genetic manipulations in Drosophila and mice and in human studies as well. So PAC6 mutations have been associated with aniridia, anophthalmia, microphthalmia, and cataract. PITS3 on chromosome 10q has been associated with dominant posterior polar cataract and microphthalmia, and FOXE3 required for lens separation and proliferation has been implicated in anterior segment dysgenesis as well, and a recessive cataract. So genetic mutations affecting specific parts are there. Crystallins, which account for 90% of the lens proteins, are responsible for about 33% of the mutations producing, gene mutations producing cataract. And the rest, mainly the transcription factors, connexins and membrane transporters and chaperones. So phenotypically, inherited non-syndromic cataracts are variable in presentation. Even inside in the family, they may present differently. Fetal nuclear cataract suggests early developmental genetic expression, mostly affecting the crystallins. The gene mutations are CRY, AAB, and BB1, and lot more. And lamellar Perinuclear opacities are common, which also affect the crystallines, mutation affecting the crystalline gene. And bilateral anterior polar symmetric non-progressive cataracts, not visually significant. We don't need to operate them. As you see here, pinpoint anterior polar cataract, but sometimes they may be associated with microphthalmia, and a gene may be involved in anterior segment dysgenesis as well, and 17q13 may be involved. Bilateral posterior polar cataract may progress later in life. We see often after 30s that they develop glare, and visually they become significant much later, though they have been there all along. And being at the nodal point can affect vision much later. And cerulean cataracts has been seen, very commonly seen in Downs. It is seen even otherwise, often phenotypically variable in severity in the same family, and they do not affect vision. Congenital cataract was the first autosomal disease to be genetically mapped in humans, and cerulean cataract was the first monogenic inheritance recognized in 9 generations of a British family in 1909 with the Duffy blood group, and later mapped to chromosome 1. And later, the next generation sequencing of families using gene panels, the whole exome sequencing, and even whole genome sequencing accelerated cataract gene mapping in congenital and adult cataracts. Other protein coding genes are associated, and GALC1 homogeneous mutations in chromosome 17q in recessive galactokinase deficiency, leading to galactosemia and galactitol accumulation in lens, producing osmotic cataract giving oil droplet appearance, as we have seen, can be reversed with a lactose-free diet after early diagnosis or even enzyme replacement therapy. So lies the significance of diagnosis in these cases. And GALC1 carriers have an increased risk of age-related cataract as well, even though they didn't manifest as a congenital cataract. So FTL gene on chromosome 19q in hyperferritinemia is an autosomal dominant condition producing crystallization of ferritin in lens, producing this breadcrumb appearance. So other common genes are glucosamanyl transferase gene, GCN22, CHAMP-B gene, mitochondrial DNA, which is associated as a maternally inherited lamellar cataract, which is commonly seen in India. We see maternally inherited lamellar cataracts, very common. We do see in our place, family, their children and grandchildren developing lamellar cataracts. HSF4 associated lamellar cataract, and some of these genes are associated with recessively inherited cataracts in Arab families and in Chinese families. So regionally there can be different genetic transmissions. And WFS1 in Wolfram syndrome with the diabetes mellitus and insipidus with optic atrophy and also cataract. So some X-linked syndromic cataracts are also there. Lowy syndrome with the mutations at OCRL gene on chromosome XQ25 with the proximal tubular dysfunction and aminoaciduria and intellectual disability. Female carriers may show radial cortical opacity, so it is good to see their parents as well, mothers as well. Norris disease is an X-linked recessive mutation with retrolental vascularized mass with iris atrophy leading to the iris later in life. Nance-Horan syndrome with X-linked dominant mutation due to mutation of NHS gene with dental molars, mulberry molars. As Dr. Soumya has already pointed out, it is good to see the systemic manifestations, see them as a whole, and the pediatric examination is very important. And chromosomal abnormalities, the most common being Down syndrome, often they come after karyotyping. They have already been diagnosed, and trisomy 13, Patavos and 18, they have all have systemic associations which produce lot of other comorbidities which affect their life quite early. So metabolic diseases, which some of the inborn errors of metabolism phenotypically, if you diagnose genetically, if they diagnose early, can be prevented. Congenital lamellar cataract, microphthalmos, short stature, PEX11B, due to peroxisome biogenesis disorder can be treated with vitamin K, DHA and restricting phytanic acid. Infantile central lamellar cataract with spastic diplegia and cirrhosis by cholesterol biosynthesis and cholesterol reduction. Childhood PSEC, posterior subcapsular microcephaly dystonia, lathosterolysis, cholesterol reducing drug can be used in these cases. Infantile nuclear cataract, as seen already, galactokinase deficiency, and congenital cataract with seizures with stromatin deficiency with a ketogenic diet, and juvenile onset lamellar cataract and peripheral neuropathy with a cerebrotendinous xanthomatosis can also be treated by chenodeoxycholic acid. So, investigating molecular etiology of congenital cataract after family history, pedigree tracing, torch titer, amino acid reducing substance analysis and metabolic diseases like galactokinase. If systemic features of delayed motor and cognitive development are there with the dysmorphic facies, karyotyping should be done, and Sanger sequencing may be done if gene is known, like Lowy syndrome is diagnosed by the pediatrician, you can go for a specific OCRL gene mapping. If genetic etiology is suspected with no distinguishable features, then whole genome sequencing can yield better results. But a targeted gene panel of cataract related genes using next generation sequencing yields better results, and next generation sequencing is the way to go now, where millions of DNA fragments are simultaneously sequenced and gene expression is better, and it is cost effective too now. Genetic testing can integrate the results into clinical practice in family planning and in prognosticating and reducing comorbidities. So, some of the gene-based therapeutics have been in trial now, even to the extent of some eye drops. Many of these genes are implicated in early onset adult cataracts as well, and gene therapy with gene editing tried in animals models. Thank you.
Thank you, madam, for that exhaustive talk. A little difficult to remember all those numbers and names. So we'll have a discussion at the end of the session. The next speaker is Dr. Satish Thomas. He'll be speaking on challenges in IOL power calculation in congenital cataracts. Over to you, Dr. Satish.
Thank you, Dr. Meena, and thank you, Dr. Laila, for giving me this opportunity. I'll be speaking on the challenges of IOL power calculation in congenital cataract. So I think what most of us in the audience will be more familiar with is how to do a biometry in an adult cataract. And so it will be good to think about what will be the differences when we have to deal with the pediatric IOL power calculation. The challenges in pediatric IOL power calculation are these. Most of them are summarized in this slide itself. One is the measurement errors. We know that children may not fixate very easily. They may not be very cooperative. The instruments that we use for measurement of both the axial length and the keratometry are all instruments which are designed for adults per se. And also they are designed usually for a sitting up position, and in these congenital cataracts we will be often measuring them in a supine position. So that can also cause measurement errors. There are anatomical differences in a pediatric, in a congenital cataract case as compared to an adult eye. The formulae that we use for biometry, they are all adult formulae. If we do a primary posterior capsulorhexis and anterior vitrectomy, it may affect the effective lens position that we anticipate at the end of the surgery. The target refraction for an adult cataract surgery we know is emmetropia, but in a child it is usually not emmetropia. And there can be an unpredictable myopic shift. We know that we are going to put it in a growing eye. There will be a myopic shift, but that can be very unpredictable. So these are all the challenges that we face in calculating the IOL power in congenital cataract. So beginning with the axial length measurement. We know that errors in axial length measurement affect the IOL power calculation the most, because of that's how the formula is. And we know from the SRK formula that it will manifest as a 2.5 diopter per millimeter change in adults. But the same thing can become a 3.7 diopter error, a 1 millimeter error in calculation in short eyes, where the axial length is 20 millimeters or less. So it becomes very important. And optical biometry is usually not possible in these children. We know that optical biometry is superior to ultrasonic because we can get it along the visual axis, and then some of the other problems of the ultrasonic calculation are not there. So therefore, but we have to rely on the ultrasound measurement of axial length. So it's usually done in theater because we don't have, we need sedation or anesthesia in order to measure that. So usually it's done just before the surgery on table. And if we are going to do that, then the immersion technique is the best method of ultrasound measurement of axial length. If we don't have access to that, then we go by the regular method. The problem with that is there will be some amount of indentation of the cornea which can affect the axial length measurement. Therefore, take multiple readings and then screen out those readings where you have the maximum anterior chamber depth, where you have the least indentation of the cornea. So this is how you can reduce the errors of axial length measurement. Keratometry, again, it's usually done on table just before the surgery. So therefore, we need a handheld keratometer to do the measurement. Again, average out several readings because these really small eyes will have a very steep keratometry, which will again flatten out as the child grows up. And try not to use the eye speculum because the speculum can alter the keratometry there. Alternatively, we can choose the IOL power which is not based on keratometry also, which is based on axial length alone. So these are how the errors of keratometry are avoided. Now coming to the pediatric IOL power, the challenge is that we are going to put a fixed power IOL for a growing eye. So if we choose an immetropic power when we are operating, then that risks a significant myopia when the eye finally matures in size. If we go for an early hypermetropia with the expectation that the eye will become immetropic during adulthood, then we are going to face the challenge of management of amblyopia. So both these approaches, either immetropia or early hyperopia, have their own pros and cons. And the best solution lies in finding a compromise between these two. So if we are going to undercorrect so that we eventually end up with the least power, how much do we undercorrect? There are two approaches. We can either undercorrect by a percentage or by an absolute value. For example, a 20% undercorrection or 10 diopter or 6 diopter undercorrection. There are tables for that. And of these, the former approach, the percentage undercorrection is more accurate. So these are some of the tables that are available. One of the earliest ones we are familiar with would be the Dahan's recommendation, where he said that in children below 2 years of age, you undercorrect by 20%, and between 2 and 8 years of age, undercorrect by 10%. There is this Indian study from RP Center by Dr. Coker, which showed that in Indian eyes, the progression of myopia isn't as much. And so they have recommended far lower numbers, which are here. Below 3 months, you would undercorrect by 20%, but at 2 years of age, only by 5%, and like that. The other recommendation for undercorrection is based on the absolute numbers by Enyedi et al. Here you have a rule of 7, where if the child is 1 year of age, then your target refraction is 6 diopters plus 6. 2 years of age, 7 minus 2, 5 diopters, and so on. So that's the rule of 7. And this is another table again, slightly different from the NAD et al. And on your right hand side is that table which gives you what IOL power to put based on axial length alone. So all these tables are available. You also need to look at certain other factors like status of the fellow eye. In a child with a monoclinic cataract or a pseudophakic fellow eye, then we need to consider the refractive status of the fellow eye in order to minimize anisoconia and consequent amblyopia. When surgery will be done in both eyes, then we can go for a larger amount of hyperopia. Visual acuity. It is probably easier in the future to manage myopia than amblyopia. So keep that also as an important consideration. And if there is a dense amblyopia, then it might be better to leave less hyperopia to treat amblyopia. And if you know that the compliance is going to be poor, then again, err on the side of emmetropia than hyperopia. Higher the IOL power, more the undercorrection is needed. And in microphthalmia, we may not get the high power of IOL that is required, so you can go for the highest available IOL power. So the last part of the presentation will be on which formulae to use. Again, as I told you before, most of these formulas that we have are all for the adults. And in the adults, these are the recommendations that I've shown you below. On these axial lengths, these are the best formulae that are there. But studies have shown that when we study them in pediatric eyes, really none of these rules that we can see in adults really apply in children. So different studies have shown that different formulae are more effective. I've just put it there. I'm not going to read those out. You cannot come out with any recommendation because one study will show one thing, the other study will show just the opposite. The infant aphakia treatment study, which is the largest trial on pediatric IOL implantation, showed that Holiday 1 and SRT gave the minimum possible errors. But again, some of the other studies have shown other findings. So it is fair to say that any formula used will give accurate results only in 45 to 50% of the patients. It may be justifiable to continue using an appropriate combination of two single constant formulas and choosing the lowest power in children. So to conclude, IOL power calculation in congenital cataract is challenging due to a variety of reasons. We have to use a combination of techniques of both the measurement and the formulae in arriving at the IOL power. But more importantly, we have to use our knowledge of the growth of the eye, considerations of amblyopia, status of the other eye, and the compliance of the child to choose the best guesstimate power of the IOL. Thank you.
Thank you, Dr. Satish, for explaining the challenges we face in calculating IOL power. Now over to Dr. Meena for management of strabismus after congenital cataract surgery, which is not uncommonly we face strabismus after congenital cataract surgery, whether unilateral or bilateral due to asymmetric refractive errors, as already shown by Dr. Satish, that it can be unpredictable. Over to Dr. Meena.
Good afternoon, everyone. At the outset, I would like to thank Laila Madam and KSOS for this opportunity. I'll be speaking on management of strabismus following congenital cataract surgery. About the incidence of strabismus following congenital cataract surgery, the range is a very wide range. Like the study shows that the rate of strabismus is almost ranging from 20.5 to 86%. So that itself shows that it's not a very rare thing following congenital cataract surgery. Obviously, there is an association between congenital cataract surgery, you have an aphakic period, you can go for amblyopia, and this itself can cause a sensory type of strabismus. So all these are associated. So this is one problem. That is the main reason for strabismus to occur. It's mainly a sensory form of strabismus. So coming to the mechanism, as I mentioned earlier, it's mostly a sensory type of strabismus, and laterality matters. That is, unilateral cataracts have got a greater tendency to develop strabismus. And also when you put the IOL, if you put a primary IOL, it will be better. Like secondary IOL, you have a period of aphakia where your correction may not be correct, and proper follow-up and refractive correction post-op. That is the most important thing, because the child's eye is growing, the refractive status keeps on changing. So maybe your power you give may be quite different after 3 or 4 months. So that itself matters, and definitely amblyopia. Now, what are the types of strabismus that you can get? Any committance, just like the committant strabismus, you can get any forms, but the usual ones that we encounter are the horizontal ones, the exotropias and the esotropias, and also the dissociated deviations are also not rare, like the dissociated vertical and the dissociated horizontal deviation. And it's not that you don't get vertical one, but these are the common ones. Now, what does the literature say? Like, the literature says that about approximately 10% of patients will undergo strabismus surgery within 5 years of pediatric cataract surgery, which may not be true in all scenarios, and younger age, female sex. So there are so many studies which give quite variable results. So that itself shows that there is no particular guideline for the treatment of strabismus following cataract surgery. And here it shows that the motor results were better than the sensorial results, definitely, especially when you have unilateral cataracts. And also, you have to be very careful when doing strabismus surgery in these patients, because results may not be predictable like you do it in a usual common committant strabismus. We had done a short study in our institute where it was to compare the biometric status of primary and secondary IOLs, and here we found the squint was assessed as a secondary variable, and we found that primary IOL was associated with very less tendency of developing strabismus compared to the secondary IOL. Maybe due to that period of aphakia, and we found exotropia was more common than esotropia. Now, coming to the management strategies, that is the most difficult part here. The when to manage is not how to manage, it's mainly when to manage and when to intervene. And usually your idea will be to treat a constant strabismus with a fair vision. So since we don't have any particular guidelines, we'll go into some of the scenarios here. Like here, this girl was operated both eyes for congenital cataract with IOL at between 1.5 and 2 years of age. And her current age is 6.5, nearing 7 years. And this is her refractive status now. Like, she has come to almost bilaterally 6/18 vision, and there is no unilateral amblyopia or anything. And she has developed an esotropia of 30 to 35 prisms. So in such cases, like when you have there is a potential for binocularity, you can go for a little early, not that early, but little early surgery. And here I would go for a bilateral MR recession in this child. So here there is no unilateral amblyopia. So there is definitely, the child has reached only 6/18, but there is still potential for development of binocularity. So here I would prefer a bilateral MR recession. Now coming to this case, which was an asymmetrical lamellar cataract. He came at 4 years of age, and he had dense cataract in the left eye with very poor vision, and we had operated in the left eye for lens aspiration, primary posterior capsulotomy, and an IOL at 4 years of age. The right eye also had lamellar cataract, but the center was clear and his vision was 6/6 in the right eye, here you can see. So he is under follow-up, but he had lost to follow-up, and he had come with a small exotropia initially itself. So at 11 years of age, this is his vision status, like 6/6 parts in the right eye, and it's only counting finger 1 meter in the left eye. And this is a dense amblyopia. In such cases, I would prefer to go for a single eye surgery, that is a resect procedure. Here it would be advisable to do. It's not that you can't do bilateral surgery, but no parent will like us operating on a sound eye, and we also will be comfortable operating on a dense amblyopic eye. So it would be preferable to do a resect surgery in this case, and that too you can wait, because whenever the cosmesis is most needed in these children, it would be the ideal age to operate. If you operate at a very young age, they can come with recurrence or overcorrection, so you have to be very careful when operating on such children. This girl again operated at 4 months of age. She underwent lens aspiration, PPC with anterior vitrectomy at 4 months, both eyes, and secondary IOL was done at 1.5 years in the right eye, and in the left eye it was done close to 2 years. So there was a gap between secondary IOL insertion in both eyes, mainly because we didn't get an anesthesia fitness because of various systemic issues for the child. And here you can see that she suddenly developed a esotropia in the left eye, and it was very difficult. Though we put an IOL later, she's still on amblyopia therapy, and here again we would prefer a recess resect procedure. And the vision is improving, but still in that small gap she developed so much of amblyopia in the left eye. So aphakia and pseudophakia one eye and aphakia one eye, it's a very difficult situation to correct or treat. So these are cases of constant strabismus, but there are conditions like variable strabismus, like here you can see there is associated nystagmus, the siblings, they are developing intermittent esotropias also, and the squint is not stable. So there are many strabismus following congenital cataract surgery which are not stable, that you can get variable esotropias, exotropias, etc. In such cases it would be ideal to wait because you don't have a proper measurement of the strabismus, so it would be ideal to wait and operate at a later age. So be in no hurry. This is an example, like you are quite justified to do a surgery in this child, a large angle esotropia following cataract surgery, and I operated at about 2 years, I think, and later the child comes like this. So you feel bad like when they come with so much of overcorrection, and though a second stage we can do, maybe it's not your mistake, but still you have to be very careful when operating on conditions of strabismus where you have associations of congenital or any form of cataract. So the second sentence explains that mistake or for being in a hurry, like you can have a delayed emergence of exotropia with longer follow-up, which indicates a need of caution in managing early esotropias in these children. This is from the infant aphakia treatment study. So be careful when you manage the strabismus associated with congenital cataract. Be in no hurry, and it would be ideal to operate on constant, and be very careful when you go for variable squints. Thank you all.
Thank you, madam, for discussing those interesting cases with strabismus and cataract and how to and when to tackle the strabismus with cataract. Next, we move on to the next session. I would like to invite Elizabeth ma'am. She would be talking on visual rehabilitation after congenital cataract surgery.
Good afternoon, everyone. I'll be talking on visual rehabilitation after congenital cataract surgery. So visual rehabilitation will all depend on the critical period. You know, the visual development will be permanently disrupted if deprived of normal stimulation in the early months of life, leading to amblyopia. And you know, human critical period for visual acuity loss is only 6 to 8 weeks of life in congenital cataract and in corneal opacities. So bilaterally visually significant cataracts should be done between 6 to 8 weeks of age, while unilateral visually significant cataract should be addressed even earlier, that's between 4 to 6 weeks. And visual rehabilitation after congenital cataract surgery is done by one of these, either contact lenses, intraocular lenses, spectacles, or later in life refractive surgery. See, this child has got a bilaterally significant cataract. The child is only 6 weeks of age. What should we do? We have to operate the patient as early as possible at the age of 6 weeks itself. The preferred surgery is lens aspiration with posterior capsular rhexis and anterior vitrectomy without IOL. Mind you, this is a bilateral cataract. The child is only 6 weeks. So we usually don't put an intraocular lens. And visual rehabilitation is done with contact lenses at least till the child starts walking. When the child starts walking, you can shift to spectacles and secondary IOL later. that was about bilateral cataract. What about a uniocular cataract? Uniocular cataract in the very young, whether to do a primary intraocular lens implant or secondary intraocular lens implant, the controversy is still there. But many more and more people are doing intraocular lens implantation in the very young age if there is only monoocular cataract. But when the child comes in an older age like this, if the eyes are straight, if there is no strabismus, then the prognosis is very good. You can do a primary intraocular implantation and the results will be very good. But if there is fixation defect or if the eye is strabismic, then probably this is of long duration and the surgical result may not be very good because amblyopia would have been set in. So if the child is above say 1 year, the preferred surgery is lens aspiration after an anterior capsular rhexis through a bibiennial irrigation aspiration cannula. First we do the incision, then capsular rhexis, and then lens aspiration. You don't need any phaco energy. There is no need of phaco probe. With the irrigation aspiration cannula, we can do a nice lens aspiration. When the aspiration is complete, you should do a posterior rhexis, and then an intraocular lens can be implanted. A single piece acrylic lens can be implanted in the bag. In the bag position is always superior. Try to do in the bag introduction of the IOL, and it is important to suture the wound, unlike in adults. In adults we don't suture the wound, but in children you should always suture the main wound and the side ports. Primary IOL implantation versus secondary implantation. In primary implantation, the challenge is IOL power calculation and unpredictable postoperative refraction. And whereas when you think about secondary implantation, the surgery is easier, but the risk of amblyopia is there. And compliance to contact lens wear is again a problem. So you have to assess each patient and give individual merit, and then you decide. When you put contact lenses, the problem is compliance. If you think that your patient is compliant and patient can come frequently, then go for contact lenses and secondary IOL later. The advantage of contact lens is that you can change the contact lens when the refraction changes, and you can give spectacles later. When you put a primary IOL, the problem is myopic shift. That is, there is uncertainty in the long-term refractive changes, and there is increased risk of membrane formation, etc. See, this is the contact lens we usually give in our hospital. Extended wear contact lens, which is a soft silicone hydrogel lens. This is locally available. These lenses can be put 3 days consecutively, 3 days and 2 nights, and 1 night we give off without contact lens. This is the one which we use, and it's locally available, and it is very good. And when you give contact lenses in aphakia, you always, in the very small child, preschool child, you overcorrect at least by 2 or 3 diopters, because for them near vision is more important than distant vision. And after 2 years, you aim the contact lens or spectacle for emmetropia, and when the child starts going to school, give a bifocal with a +3 addition. And when do you give contact lenses or glasses after surgery? It has to be done very early. Means aphakic babies, refractive correction should be done in the first 2 weeks after cataract surgery. Usually we delay. The patient comes after 1 month, 1.5 months. You are reluctant to put contact lenses, and you lose the big precious time. So we have to put contact lenses 2 weeks after congenital cataract surgery. And older pseudophakic children can wait, of course. See, I would like to invite your attention to the infant aphakia treatment study, which compared contact lens with primary IOL implantation in the younger age group. And the infant aphakia treatment study didn't find any statistically significant difference in the vision in the 1 to 6 month age group after 1 year follow-up. In those people, with contact lens or with IOL. But the complications are more in the IOL group. This I have already shown. So, in addition to all these things, long-term monitoring is very important. We have to do multiple refractions, look for complications like glaucoma, retinal detachment, posterior capsular opacities, and strabismus. As Dr. Meena has already said, many of these children will go into strabismus. And the most important reason for strabismus, one, the child may be hypermetropic and the child may go into accommodative esotropia. That's one reason. Another is amblyopia. If there is a difference in the vision between the two eyes, again it can go into strabismus. What about multifocal IOLs and EDOF IOLs in children? What I would say is that it's a cautious optimism. Larger studies and longer follow-ups are required before deciding on multifocals and EDOF IOLs. But nowadays, more and more people are using these lenses in a child who is more than say 3 or 4 years. But the problem is these children will have a difference in the refractive power, and anyway they need spectacles. Then why don't you give spectacles instead of EDOF lens? That is the argument behind that. And we have to address the question of amblyopia also. When you think about the management of challenges of vision therapy and vision rehabilitation in congenital cataract, amblyopia can be due to stimulus deprivation, form deprivation, and ocular rivalry. In case of unilateral cases, patching regime is more stringent than what you do in strabismic amblyopia. In infants with unilateral cataracts, patch on the unoperated eye, 1 awake hour per month of age. That means a 1-month-old child should have 1 hour occlusion if the child is awake, and a 3-month-old child should have a 3 hours occlusion. A 6-month-old infant should have a patch of 6 hours in the good eye. And after 8 months of age, the dictum is you occlude 50% of the waking time. That is the patching regime. One has to be very careful about this. The patching regime in congenital cataract is more strict and stringent and more prolonged than in strabismus. Occlude the fellow eye at least 50% of the waking time. This is the recommendation published in European Journal of Ophthalmology 2007. And after occlusion, you can have some stimulation with flashlight like this. And in an older children, you can resort to other forms of vision stimulation exercises, including binocs. And one word about myopic shift in pseudophakia. Nowadays, when the refractive power, myopia increases in children, we give this low dose atropine, and the effect of low dose atropine in pseudophakic myopia is not established. And usually we don't give atropine for the progressive myopia in pseudophakic children. But of course, if you can monitor and document that the axial length is elongating, probably you can have a trial, but this is not proved. And role of refractive surgery, both PRK and LASIK can be done to correct postoperative myopia in older children. And when the child is older and the patient has gone into myopia, you can have exchange of IOLs, or you can have a piggyback IOL inside the eye. And one word about the visual outcome, even in the best centers. Even in the best centers, 6/18 vision in a congenital cataract operated is supposed to be good. And I would like to say one thing, that there was a large study done in the blind schools of India. And in Indian blind schools, more than 50% of the children who are blind are due to either bad congenital cataract surgery or unoperated cataract surgery. That is an eye-opener for us ophthalmologists. One take-home message, the most important thing is you have to diagnose congenital cataract as early as possible. So the red reflex test in the newborn nursery is most important thing to detect congenital cataract as early as possible and do the surgery as early as possible. Delayed surgery result in amblyopia, nystagmus, strabismus, and optical correction I have already discussed. Just remember that amblyopia, aphakia is as amblyogenic as cataract. Those infants who undergoes aggressive treatment will attain good visual acuity. Thank you very much for a patient hearing. Thanks, sir.
Thank you, Dr. Elizabeth, for that wonderful talk and stressing upon the importance of follow-up. Congenital cataract surgery is not the end, and it's not just enough to do surgery as soon as possible. Amblyopia management and follow-up for glaucoma, strabismus, patching, all these need immediate attention as well, and the earlier the better.
Actually, most of these are covered topics, like we are more, the doubts arise in the gene therapy and all those things. So what are your experiences, or when do you send a child for, child or parents for all these workups?
Madam, there are multiple mics there. There are 4 mics there on the table.
Pardon? Okay. So, considering the cost factor, when a child comes at 4 weeks or 6 weeks with a bilateral cataract, unilateral cataract, of course, we are more concerned about the other ocular associations like PFV, any other associations, posterior segment abnormalities, you do B scan, other associations, even glaucoma can be associated, and follow-up is also more looking for ocular associations. But systemic associations, of course, infectious causes a very important factor. But bilateral cataract, you have to propose that a genetic study is indicated, especially when there is a, definitely we have to do a pediatric assessment. If there is any other association, we might miss many of the associations, even if you look for other associations of syndromic cataract. So a pediatrician should look for these things. And then we should suggest the patient that you should have a genetic assessment later. Very often the parents ask us why it has happened. So in such cases, definitely we can tell them you need a genetic assessment later. We cannot say now. So we can put off a genetic analysis for a later date, need not be before the surgical management. Familial history is often there. Even if it is not there, we can do a genetic analysis. That is what we do now. Not all patients undergo. Now what we do is we accumulate the cases, and there are some centers like MedGenome who are willing to reduce the cost for doing a genetic analysis, this whole genome analysis.
Just one question to Soumya. Do you send for PCR, rubella cataracts?
We were
And
actually
the cost also, do you know?
we were actually planning for that kind of a study because it is very specific for detecting. Otherwise, whatever we do, serum. Yeah, we should know the cost. Thank you.